All right.
Well, yes, thank you. Okay.
And I apologize. I'm actually not in Montana right now. We did a last minute vacation. So as usual, my timing is very impeccable, but you guys can hear me okay?
Yes.
Okay, perfect. All right. So yeah, thank you so much for giving me an opportunity to talk with everyone today. So we're going to talk about some new and exciting treatment options for drug-resistant epilepsy in Montana. And kind of a brief outline will go through. I'll briefly talk about who I am, why I'm talking to you guys. I will really briefly discuss drug-resistant epilepsy, and then go through some approaches we take to it, including anti-seizure meds, and then focusing a little bit more on kind of new and exciting therapies that weren't available even a few years ago in terms of neuromodulation approaches, as well as some older therapies like dietary, which can still be really effective even if medications have not worked. Um, and I think as we go through this, just if somebody has questions, you can maybe let me know or let Jessica know, and I'm happy to and talk about it. So hopefully this can be somewhat interactive. Um, so about myself, I'm from the East Coast originally. I'm now based out of Whitefish, Montana in Logan Health. I have a wife and an 8-year-old kid, daughter, and most of my education, or all of it really, was on the East Coast, including a long time over at Duke where I did residency and fellowships and then subspecialization in EEG and epilepsy. So broadly often called clinical neurophysiology. I was a assistant professor there for a few years and mainly managed drug-resistant epilepsy. I also ran the ketogenic diet center there and also the first-time seizure clinic. So kids who showed up after having a seizure for the very first time. It's kind of I think an important part because you have so much to go over and explain. And so having a clinic dedicated to that where we could get folks in quickly was super helpful. And then the past almost 3 years now, we made a big move and moved out to Montana. So I'm now at Logan Health. I still maintain some faculty affiliations at Duke and also with the Seattle Children, so University of Washington. So still get residents and then medical students and folks who rotate with me when they're kind of doing their external rotations in Montana. So yeah, kind of this is a nice illustration of the challenges we have when delivering child neurology and epilepsy care. So we're based out here in Kalispell, and there's a huge part of the state that we're quite far away from. So we do a lot of outreach work. So I go to Missoula, Helena, Great Falls, and Bozeman. Missoula, I'm driving to, but we also lease a little propeller plane. So myself and other specialists will fly. Myself, I go once a week to these other areas to make it easier for families to see us. Here in Kalispell is still kind of our headquarters, and it is myself, another MD neurologist, and we have a nurse practitioner who works with us as well. And we are, since I've gotten here, offering a lot more services, including overnight EEG monitoring, VNS surgery, which was already getting done, but we're doing more so now. We have other specialists like pediatric neurosurgery. So Dr. Schmidt is excellent, and I work with her closely. We're starting to do some limited ketogenic diet therapies. And then also the really exciting stuff is things like RNS or NeuroPace, which wasn't available before. We do have a neonatal ICU and pediatric ICU, so that we can kind of handle more complicated cases when they pop up, as well as some genetic services. I want to mention this is kind of a new thing. Logan Health is merging with Billings Clinic. So there is a child neurologist, Lynn Wood, who I work closely with as well. She's excellent. We have done overnight EEGs over there as well. And that's kind of another unique thing is I do read EEGs and basically all the big centers. So, and you can do it remotely, which is great. Families don't have to travel to Kalispell to get basic stuff like that done. So kind of moving on, what is, and Jessica, I don't see the chats because I have this in full screen. So just let me know if there's questions or something else that pops up.
Okay.
And also if it's really loud, let me know to speak up. Hopefully the birds aren't too loud. All right, so what is epilepsy? it's 2 or more unprovoked lifetime seizures, meaning that for no reason, a child has a seizure. If somebody were to get in a car accident and injure their head and have a seizure right afterwards, that's what we call a provoked seizure. In this case, it's not some external factor that induces a seizure. The other newer definition is having one lifetime seizure, but then having a very high risk of seizure recurrence after that first lifetime seizure. So more than 60% is kind of the cutoff that's used. How do you predict seizure recurrence? A lot of it is based on whether EEG shows seizure risk, brain imaging findings, and then uh, other risk factors, like, for example, brain injury at a younger age or other history like that. What is drug-resistant epilepsy? There's some debate whether it's 2 or 3 medications, but generally speaking, if you have failed 2 or more medication, we start to worry that you have drug-resistant epilepsy. We'll go through some of that data in the next slide. The other term I'd like to introduce as well is epileptic encephalopathy, which I think of as maybe as a subset of drug-resistant epilepsies, where basically, in addition to seizures that are hard to treat, the seizures may also negatively affect other aspects of the child's development. And so maybe you have loss of developmental milestones, or regression is the other term for that. Sometimes psychiatric symptoms, sometimes movement disorders. And so basically the seizures kind of amplify all those other issues as well. So it's not just managing the seizures, which is kind of a theme to a lot of what we do. All right, so yeah, when do you know that it's a refractory? So this is kind of one of the earlier studies to kind of predict a percent of folks who get seizure freedom, and this is adult and kids. And let's say somebody has a seizure for the first time. When you add the first med, you have a 50% chance of achieving seizure freedom. If they still have seizures, if you add a second med, there's a 12% or so additional patients, so 62% total, who achieve seizure freedom. If you add a third med, if you're still having seizures, there's another maybe 5% or so folks who then get seizure freedom. When you're looking at your fourth or fifth medication, if you failed, 3 already, you can see that the additional benefit kind of decreases. So really, once you're on a third or fourth med, it's less than a 3% chance of achieving seizure freedom just with adding additional meds. And that's when we start thinking about other possible interventions. And that's where that rule saying 2 or more meds or 3 or more meds comes from, saying now we are worried this is drug-resistant epilepsy. And the statistic you'll often hear is about 30% of patients, which you look over here, have drug-resistant epilepsy. When do I get extra worried? We briefly kind of talked about that epileptic encephalopathy earlier on in the slides. So if a child also has some developmental differences in addition to the seizures, so that could mean issues with talking or speech, motor concerns, so difficulty walking or crawling, or doing fine motor tasks like using utensils. If a child also has issues with like feeding themselves or need a feeding tube, so all those things make me more worried about the seizure type we're dealing with. And then the big thing that I always mention is regression. So if a child is meeting their milestones or making progress developmentally, but then starts losing that, that's when I start to worry more and want to get more aggressive with treating the seizures, because I'm concerned that if we don't treat them aggressively, you have more of these developmental issues. And then there's other comorbidities. So if a child is having some psychiatric symptoms they didn't have before, new movement problems like kind of, a tremor or balance issues and so forth. And like I mentioned above, cognitive decline. So more issues with thinking or memory and things like that. Really briefly, just to give you like kind of a taste of the more difficult to treat epilepsy syndromes. And I'm sure some of you are more familiar than others with these specific types. So West syndrome is kind of the big one we worry about in kids less than a year old, but can be even 1 to 3 year of age period. But really in the first 6 to 9 months of life, this is where we worry about it. You have a seizure type called epileptic spasms or infantile spasms, which are really, really kind of quick jerks that can cluster and happen over and over again. There's a EEG pattern called hypsarrhythmia. So this is an example. It's a very chaotic, disorganized EEG pattern compared to kind of what you typically see in that age. So this is an example of sleep spindles that in this EEG you don't really see much of. And these two things are associated with developmental regression or sometimes stagnation, meaning that you stop gaining milestones even if you don't necessarily lose them. The spasms are occurring only sometimes. When it's full-blown West syndrome, the hypsarrhythmia is there all the time. So really, instead of healthy kind of EEG brain activity that helps a baby develop, you have this activity that's just kind of promoting more seizures. And so our goal is to get rid of this as aggressively as possible and turn it into this. Early identification treatment, super important. So this was just a study looking at kids who were treated within 30 days of developing spasms versus afterwards. And this is not percentage, but kind of raw number. So out of 54 kids, almost half of them had normal development and more than half became seizure free if treated early. And then those numbers kind of really dropped drastically. So this is a reason why we tend to be more aggressive and upfront with this and other epilepsies that I'm worrying more about, because you don't want to wait and kind of, wait 6 months before you do anything. You really want to see if the med works, and if it doesn't, go to the next step. So the prognosis is very guarded with infantile spasms. The mortality is probably not as high as 33% anymore. So that's probably data more from like the 70s, but it's still higher than in a otherwise healthy infant. And then there's definitely concerns about developmental delay in this patient population. The goal is that you minimize this as much as possible, again, with early treatments. And then the other issue is you can develop other epilepsy types. So the spasms, all kids will grow out of eventually. But other seizure types will develop. And often it's something called Lennox-Gastaut syndrome, which is kind of oftentimes where you progress to from West syndrome. And this is a lot of the patients I treat will have some variant of Lennox-Gastaut, or LGS for short. So this is a syndrome that happens when you're a little bit or earlier, usually before you're 4 years old, but can be in a 2 to 8 year range, and you have multiple daily types of seizures. So tonic and atonic, both of those can cause something called drop attacks, meaning you get really stiff and you fall over, or you lose tone completely and fall down as well. You can also have myoclonic seizures, which are really, really quick jerk type seizures, atypical absence, which can look like staring, and then other types of seizures as well. There's, again, a specific EEG pattern that helps us make this diagnosis. And again, if we don't treat this aggressively, or even if we do treat aggressively, you often see some developmental differences as well as sometimes regression, which is what we try to avoid as much as possible. Again, prognosis is more guarded because it is a more drug-resistant epilepsy. A large percentage of these kids will have some amount of developmental differences. About 40% of them are able to do daily activities independently. A quarter of them have issues with walking. And the big thing here is we care about all of these things and try to minimize the impact of that. Oftentimes, because we just went over the statistics, you can't eliminate seizures completely. So the goal is to decrease seizures, or maybe get rid of the bad ones that are more kind of potentially more harmful. So drop attacks, if you're injuring your head because you're falling down a lot, maybe we can at least get rid of those, even if we're less successful getting rid of the absence type seizures, for example. So what do we do about this? This is kind of the more exciting part, hopefully. There's the first thing we always start with is anti-seizure medications. There's a lot of factors. It's what type of seizures you're having, how old you are, what a child is able to take. Like, can they swallow a capsule or a pill? Does it need to be liquid? Is the med affordable? Is a huge issue, and that's unfortunately a lot of our time is spent sometimes fighting the insurance companies to approve some of the newer medications. And then you're thinking about other factors that affect quality of life, or like if there's other issues, like for example headaches, maybe you want to use a med that can kind of help prevent headaches and so forth. So we try to take all that into account when making decisions. This is like just a nice illustration of how many new medications we have available compared to, say, the 70s or 80s. You can see this is kind of all med prescriptions or all anti-seizure medication prescriptions. We really had 3 or 4 until the 90s. And then really the past 20 years or so has been really exciting because there's all sorts of different medications we can use, which has hopefully improved kind of the quality of care that we can deliver. And there's more and more meds are coming out. So it is an exciting time. Or it's exciting to be in a time where we can offer more treatments. Obviously, everyone wishes epilepsy is not an issue we have to deal with, but it is nicer to be here and have lots of options than here. Again, I'm not going to go into too much detail, but what I kind of think about in my mind is what type of seizures is a child having? Are they focal, meaning coming from one part of the brain and then spreading? Are they generalized, meaning your whole brain kind of goes off with the seizures? And it's not one area that's causing the issues, or do you have a mix of both? And so all that impacts what meds I'm thinking about. The other thing I'm thinking about, and I'm not going to get into this, but all these meds work by different mechanisms. And what I try to do is, if we are having to use multiple medication types, target different mechanisms of action. So, maybe you don't want to put a kid on multiple meds that all target the sodium channel, because it might be a less effective way to treat seizures. So I kind of keep all this in my mind when I'm making decisions in terms of what medications to choose. There are specific meds that are approved for specific epilepsy types. Again, so for example, juvenile myoclonic epilepsy, these might be the meds we tend to use more. For infantile spasms, we start, for example, with high dose steroids or oral steroids. So ACTH is injections, this is oral. So really you're thinking about where is the data show for these specific seizure types and what med makes the most sense to use. Let's see here. So yeah, and so basically, let's say we've oh, there we go. I think I got skipped a little bit. So there's a lot of options, and it is a kind of, you have a long conversation about what those options are, what makes sense for the child, and what the parents feel comfortable with. And I think in all of this, it's again important to mention it's a discussion. There's not one right answer here. With some medical conditions like appendicitis or something, if you need surgery, you need surgery, and that's what you need. With epilepsy, there's much more nuance, and so it is a conversation, and we got to figure out what everyone feels this makes the most sense to do. So some newer meds to be aware of. So a lot of it has been for seizures associated with Lennox-Gastaut syndrome. And a lot of what I talk about is off-label use, meaning the FDA approval is for specific seizure type. In pediatric neurology, almost, I don't know, 80% of what we do is off-label, because unfortunately kids are less studied. And so we don't have that controlled trial to say, okay, this is why we need to use this med. So we're often extrapolating from medication trials or studies that were done in adults. That being said, so these meds were approved for seizures associated with Lennox-Gastaut. Epidiolex is not super new, but it is newer. So that's CBD oil. So it's a kind of the non-THC marijuana extract. It can work really well for atonic seizures. Really, all seizure types could benefit from it potentially. Fenfluramine is the med that came out just in the past couple of years, which also is approved for LGS. And we haven't been using it that much, but there's some promising data in terms of its use for something called Dravet syndrome, and some okay data for its benefits in Lennox-Gastaut. And rufinamide and perampanel, so Banzel and Fycompa, also approved for drop attacks. But all these meds are pretty broad spectrum, meaning that you don't necessarily need to have Lennox-Gastaut to have benefits from it, but are new ones to be aware of. The other one we've been using more, again, this is off-label, is something called cenobamate or Excorpi, approved for focal seizures, but again, seems to work for some other seizure types as well. So if we feel kind of the first meds we use most often, there's a lot of newer, interesting options or potential use. There's a lot more meds on the horizon. There's a lot of studies, and luckily there's, I think, more effort being put into studying epilepsy in kids compared to even 20 years ago, and kind of putting more medication options for folks. And so the other part that we're going to talk about is the non-pharmacological therapies, which we end up doing a lot of once you failed kind of the first round of medications like we talked about. One of the oldest therapies that's existed even before medications are available is ketogenic diet. So it's an extreme high fat and low carb diet. So in the most kind of most restrictive versions of the diet, we're talking less than 2 grams of carbs a day, which if you look at any granola bar, just one of those has 30 or 40 grams of carbs, just as a point of reference. And we can also do less extreme versions of this where you're maybe restricting to 20 or 30 grams of carbs a day, which sometimes is often easier to do than the more restrictive ones. But if you are doing the restrictive one, you have to be calculating out and weighing each food type, really understanding how the carb and fat count and protein count of all these meds. Even in kids with drug-resistant epilepsy, can be very effective. So 15-16% can achieve seizure freedom, and 30% can have a 98% or more reduction in their seizures. About half the kids have at least a 50% reduction in their seizures. I've seen anecdotally, and there's some data that it seems to help with developmental development as well. Like cognition seems to be improved, focus, and so forth. So it seems to have some secondary benefits as well, in addition to seizure control. Um, this is just a nice diagram of the ketogenic food pyramid, which is kind of probably the opposite of what we were taught, or a lot of us were taught in school. So really, you're getting most of your nutrition from fat. You get your daily allowance of protein that you need for your body to function, and then minimize the carb part of this. Can be a very restrictive diet. So kids who are very picky eaters, if you're not meeting your calorie goals and you're depriving the child of carbs and kind of only using fat, that can cause more weight loss and other issues. If you're already underweight at baseline, it can be really difficult to maintain the diet. And then there's certain pretty rare metabolic conditions in which therapy is contraindicated. Typically, I'll be screening for those things and ruling them out before putting a child on a diet. Sometimes social situations and other things will make adhere to the diet difficult. So kind of changing diet can be financially difficult. It depends what stores you have available nearby and so forth. So there's a lot of factors that can make it difficult. And then you can do the diet either with regular food or with formula. So if a child gets their nutrition through a feeding tube, in some ways it's easier to start a diet because you have formula that's pre-made, that's ketogenic, and then you just switch it out for the formula they were using. And like I said, there's less extreme versions like the modified Atkins diet. So what are we doing here in Montana? So we have a dietitian. We had a ketogenic dietitian right when I joined, who unfortunately moved to Idaho. But I work with a dietitian in the GI department who can help with tube-fed ketogenic diets. So to figure out how many calories you need, what a good feed regimen, and so forth. And then I am providing guidance, just because I've been doing it for a while, on the less restrictive versions like the modified Atkins diet, where you're really just carb restricting and not being too aggressive. Otherwise, at some point, we would like to offer more restrictive versions, but you really need a kind of hands-on dietitian who would calculate each meal and so forth. So it's kind of our goal, but we are starting to do some limited services, which is good progress compared to not having this. So we talked about keto. So epilepsy surgery. So that's another kind of big thing that we always talk about. Once you have drug-resistant epilepsy, what it means is that you're taking a part of the brain that is causing seizures. Hopefully, it's coming from a region that is not responsible for other important functions, and you can actually resect or cut that part of the brain out and eliminate the seizures completely. So this could be a curative treatment for epilepsy. It can be used in non-curative cases in specific situations. So this is an example of this is a child who has something called tuberous sclerosis, where you have these masses that kind of form in different parts of the brain, and it can cause a variety of seizures and other developmental problems. And what you can do is, once we figure out that it's coming from this area, it can actually be resected, and you can see an EEG background that's kind of very more disorganized and angry looking, become really calm from kind of doing this. And so it can be very effective. In tuberous sclerosis, it's typically you have multiple tubers, so you often need multiple surgeries. So there are sometimes not the ideal surgical candidate, but you can have still a tremendous impact even if you don't get rid of seizures completely. So what can we do at Logan Health? The main thing that I've been working on since getting here is creating like an epilepsy medical home that's in state. So before, families would basically, for any sort of evaluation, like a surgery, an option, would have to travel out of state. And we can do a lot of those stage steps here. So the really first thing is we get an overnight EEG, we catch seizures, we figure out if they're all coming from a specific area. And then we discuss if more invasive monitoring or surgery is indicated. And so those type of things we can now do in-house. We can get brain imaging to see if there's a specific brain area that is potentially causing seizures. And the whole goal of doing this in-state is we determine if the child is a good candidate for further epilepsy surgery care. Do they need to be referred to a comprehensive epilepsy center? I work most closely with the children's folks, variety of reasons, both kind of regional in terms of where we're located, and also just through the research and other reasons. I knew those folks a little bit better, but I've also worked with folks from University of Utah, University of Colorado, Mayo and Nebraska area, less so. But bottom line is there's a lot of good centers in this region. You don't have to go to the Northeast or, or Texas or something. So we have a lot of good epilepsy centers where we are. I meet with the Seattle Children's folks. We have a weekly conference where we go over patients, where we're discussing whether they should be considered for epilepsy surgery. And it's really helpful because it saves families times and effort to travel. If surgery might not be a good option, let's just say there's too many parts of the brain causing seizures, or the seizures are generalized, so there's not really a point to put a child through additional surgical interventions. And again, like I said earlier, kind of serve as an epilepsy-related medical home. That's what we hope to be through our presence here. If a child is a good surgical candidate, I can kind of go through what does this mean? What are the next steps? Because we have to often deal with something called invasive EEG monitoring. And once that is done, you have clear follow-up and somebody who knew what happened before the surgery, what was done during the surgery, and what happened afterwards, and really try to avoid something that might have happened in the past where you kind of get sent out of state and then come back and nobody knows what happened, but we know that some sort of surgery happened. So really try to coordinate that sort of care because this is a very complex process and a lengthy process. And then, so what other things? So let's say epilepsy surgery might not be the best option. So maybe a child, they thought the seizures are coming from, let's say, the temporal lobe. We send them over to an epilepsy center where they did surgery to listen to the seizures more closely, so the invasive EEG monitoring. But it also turned out that that area is responsible for something like speech. That's something we can't resect or cut out, or usually it's not a good option. So what else can we do in those cases? And 5 or 10 years ago, was not much, unfortunately. And so it is an exciting time to have more therapy types. The most kind of the one we've been using the longest in terms of other interventions is vagus nerve stimulation. And I just use the term neuromodulation. What that basically means is any sort of electrical signaling that we manipulate to decrease seizure burden or improve brain function, or to decrease epileptiform activity. So the VNS, basically, it's a device that gets implanted under your skin in the chest. There's a wire that goes to your vagus nerve. And then through that wire, you have a signal that gets sent to the brain that has a calming effect on the brain. The kind of other benefits is the newer devices actually listen to your heart rate. Oftentimes seizures increase your heart rate. So if you're having a big seizure, your heart rate goes up. This device can detect it and then send an extra signal to try to stop the seizure when that happens. Or if a family witnesses a seizure, they're given a magnet, and so you can swipe the magnet across the VNS, and that will also set off the device to help stop the seizure. It is not brain surgery, but it is a surgical procedure, and it's usually you're in and out the same day. It's a pretty straightforward, a very straightforward procedure, and it's not as invasive as a lot of other things, and it can be effective. So less than 5% of patients get seizure freedom through the VNS. However, more than 50%, maybe even closer to 60%, have their seizures reduced in half. It can help mood, so it does have an FDA approval for depression, even though I have not seen it used too much for that, but seems to have some cognitive benefits eventually. And the longer you have it in, the more effective it can become. So, so kind of a really good option if surgery or other interventions are not, possible. So this is what the device looks like, and this is actually this is the one we tend to use. So when you come to clinic, we interrogate the device and I can change the settings. This is what the magnet looks like, and that's what folks use to kind of swipe the VNS to help stop the seizure. So some things to think about. It is a surgical procedure. There's some risk of infection. That being said, it's usually the benefits outweigh the kind of potential risks, especially if you're having really bad seizures. It's not a curative procedure, but it can reduce seizures. The VNS battery does run out. The average is about 5 years, but depending on settings, it could be 4. Sometimes I've lasted 7 or 8 years. It just depends on what settings we end up needing to use. 80% of families choose to re-implant the battery, meaning that they found it was effective enough, or they found enough benefit to go ahead and do another smaller procedure to replace it. And again, we strongly think about this is often the first intervention we think about if you have drug-resistant or refractory epilepsy, and where other options are limited. What are we doing here in Montana? So Dr. Schmidt, our neurosurgeon, she does a lot of these. So we're doing them up in Kalispell. It's not something we're doing in other cities, but it's better than having to travel out of state. And then we can do settings adjustments anywhere I go to outreach clinic. We have devices in Bozeman, Great Falls, Helena, Missoula. And so that makes it pretty easy to kind of have follow-up. Another cool new feature with the newer devices is we can actually set a protocol to automatically increase settings after the VNS is placed, or for folks living, up by the High Line or other areas where it's really hard to get to. This is a nice option, so you don't have to keep driving back, even if, say, Great Falls is kind of far for you. So what else? So let's say VNS was tried and didn't work, for example, or maybe there are reasons why the families didn't want to try it. What other options do we have? And one of the kind of newer exciting treatments is responsive neurostimulation, or RNS. So it's the company that makes it, or I guess the device itself is called NeuroPace. And what's really cool about this is it's a more invasive procedure, but you're basically implanting an EEG lead to listen to the seizure directly from the area. So this is an example where the temporal lobe might be causing seizures. And what happens is we train the device to learn what the seizure pattern looks like, and then the device automatically then sends an electrical signal to stop the seizure when it happens. So let's just say, for example, we did invasive EEG monitoring over at an academic center, and this area, even though it was causing seizures, was also responsible for speech. So if we were to cut it out, you would lose speech abilities. That's not a good option. And so RNS might be an alternative, because now you're not resecting anything. You're just kind of going to be zapping the seizures when they come out. The battery is outside the brain, so it's kind of on the skull, but under your skin. It's not super big. It's not invasive. And so it's again definitely a bigger surgery, but it's not a super invasive procedure, and really helpful when other options are limited. A big thing is you do need to collect data first. So basically, when families see a seizure at home, they can use a little magnet to kind of mark it in the EEG file, and then you use a wand at home to upload the EEG data. And then what we do is there's a machine learning algorithm setting adjustments we make, so that basically the RNS learns that pattern, and then it automatically learns to detect that seizure pattern and then zap the seizure to stop the seizure. And this is all done remotely and wirelessly, which is really nice. It's at least for collecting the EEG data. So this is an example, and this is another reason why this is kind of exciting. So what we get is something called electrocorticography, or ECOG, meaning this is direct kind of seizure activity we can see, and I can download the data for. And then this is the device basically sending an electrical signal to try to stop the seizure. Sometimes it's successful, sometimes it's not. But then we can kind of go up on how strong the stimulation is and so forth. So you get a lot of really granular data, which you don't get from something like a VNS, for example. And so it is kind of helpful to have that additional information and really try to target the seizure as specifically as possible. This is an example of a patient who had one implanted, and it's just basically you can see the decrease in seizure frequency over time. It's not a fast process. There's kind of 2 steps forward, 1 step back type of situations, but overall still get, a reduction in seizures that's quite high. So going from, this is not exactly seizure counts, but basically periods where seizure type activity was reported, or epochs. But even using that, you can see there's, almost at least a 50%, if not more, reduction in seizures to compare to before. The other thing we haven't used as much, but is starting to be used, is deep brain stimulation. It's like a VNS in terms of it sends a signal every few minutes to the deep brain structures. It doesn't listen for the seizure, but it can be very effective as well. This device gets planted in your chest, so it's not kind of on the skull, but there's a wire that goes down to the chest. And it can be a reasonable option as well. I want to mention, I guess, one thing going back here. So I mentioned the example which its FDA approval is for, which is focal epilepsies, meaning a part of the brain is driving the seizures. We have been using it more off-label in cases where the epilepsy might be generalized, meaning the whole brain is going off during the seizures, like the cases often with Lennox-Gastaut syndrome. And in those cases, we're actually implanting something called depth electrodes to the deep brain structures and listening for the seizures there. And it can be really effective. There's actually now a trial happening through NeuroPace looking at generalized epilepsy and how well what this approach works. Anecdotally, again, when other options are limited, when medications are no longer, they're no longer good medication options, it is nice to be able to offer that. So it's not just for focal epilepsies, but we're starting to use it for generalized epilepsies as well. And so kind of back to the DBS, also can be very effective. It doesn't listen for the seizure. It just kind of passively sends a signal every, time, a specific time duration, but it can work as well. So what are we doing at Logan Health? The big thing is if other options are limited, we refer you to the Comprehensive Epilepsy Center, where then I work mostly with Dr. Houtman out of Seattle, but again, there's folks in Utah as well who I've worked with, but they can do the initial implantation in the part of the brain where the RNS would be helpful. And then we can do all really of the subsequent care in state. So programmer settings, adjusting stimulation strength, adjusting the algorithm in terms of how you're detecting the seizure. And we can do it in all the outreach locations. So again, sometimes families have to travel on a monthly basis to Seattle or Utah, and that can be really financially difficult, logistically difficult. So it's really nice not to have to do that. We've had one issue with a battery, so we're able to do that in-house as well. So Dr. Schmidt, again, I collaborate with her really closely. Again, this replacing a battery is not brain surgery because it's kind of on top of the skull, so it's a less invasive procedure, but a lot of the follow-up care can be done without traveling out of state. So let's see here. So big conclusions here. It's super exciting to kind of deliver more epilepsy services in Montana. I think we've made a lot of good steps over the past few years in terms of EEG monitoring and RNS and a lot of other things, referring people for surgery when it's indicated to hopefully decrease seizure burden in the state. There's a lot of good new medication options. There's dietary therapies, and then the neuromodulation part has been really exciting. And most importantly, and I said this earlier, it's really important and helpful to serve as a medical home in the state for epilepsy care. Know when it's worth it to send you out of state. Know when it's probably not indicated, and save family the financial strains of doing that. And then being there to guide families through what can be a very scary process, particularly when it comes to epilepsy surgery and follow-up before and afterwards. So that's all I got, and hopefully there's some time for questions if families have some. And you obviously have contact with the Epilepsy Foundation in Montana. Definitely reach out if you have questions or interest in referral, and you can always reach out to us as well in Kalispell and Logan Health. So that's all I got.
Awesome. Thank you. That was super helpful. Thank you for all the work you're doing. We do have a few questions here. First of all, are you going to start seeing patients in Billings?
So we currently don't have plans to, because Dr. Wood is based out of there. What we've done, and again, with the merger, we'll see how things kind of pan out, because we're already doing Bozeman. That's as far east as we go. What I have done in some cases is, and actually we've done this for some adult patients as well, if they already have a primary neurologist, but there's questions about med options or more invasive type of stuff, I have done video visits. I do a lot of video visits as telehealth from home. And so realistically, that's the best bet. I do like a person to have seen a neurologist at some point so they can do a full exam, make sure there's nothing else going on, because obviously doing that through video is challenging. But when it comes purely to seizure care, we can do it through telehealth.
Awesome. All right. Also, once the child has an ESES episode, are they considered to have ESES epilepsy? And then also, are they more likely to have it occur again? You're on mute. We lost you there for a second.
Sorry, I said, okay, so ESES, So ESES is short for electrical status epilepticus in sleep, which basically is silent seizure activity that's near continuous in sleep, and it can be associated with loss of developmental skills, so loss of speech, or sometimes more broad developmental regression. And that EEG pattern comes as part of epilepsy, specific epilepsy syndromes. So kind of the classic one is called Landau-Kleffner syndrome, where you often have clinical seizures, but also have this ESCS pattern. And usually these, what I would say is ESCS is not an epilepsy syndrome. It's a pattern you see with some more drug-resistant epilepsies. So usually if you have ESCS, you're going to have epilepsy, and often it will be drug-resistant. So I don't mean to be convoluted, but hopefully that kind of answers your question.
Okay. And then earlier in your talk, when you referred to the number of meds, were you referring to just prophylactic meds or emergency meds too?
So in the context of this discussion, I was talking about daily medications to help prevent seizures or reduce seizure frequency. Rescue meds, I didn't go into as much, but it is a big part of what we do, certainly in kids who have frequent seizure clusters or big seizures that need to be stopped. Typically, those are going to be benzodiazepine type of meds, either nasal sprays or sometimes oral dissolvables. But yeah, the talk was in reference to the daily prophylactic meds.
Okay, thank you. And then are you going to see adults for RNS anytime in the future, treatment and or surgery?
Yeah, so that's the goal, and I've talked to the RNS folks just because it's a limited resource. That's our goal. So I think it would be great to start seeing adults and making those setting changes as well, so they're not having to travel out of state. I
Awesome.
believe there's a provider in Great Falls. I don't remember his name off the top of my head, who has been doing some RNS setting changes. I don't believe they do any sort of outreach. So the goal is to kind of bring the RNS services to Bozeman, Helena, yeah, and Missoula, and so forth.
Okay. And then Robin was asking, how does one access this information that lives in Portland? We recorded this session, but Robin, does that help you?
Hi, so yeah, I just have a friend that's on here that lives in Portland, and she's having a hard time with some of her care team over there. So I was just wondering, how she could access some of this information, but she's watching this as well. So
Oh, she joined? Oh, okay.
yeah.
Perfect. Great. Sure. Okay. Anything else? I think we have a small enough group. If you just want to come off mute and ask your questions, we have time for that. Right.
I have a question. Do you have plans to have a first-time seizure clinic at some point?
We've been unofficially doing that. So there's first time seizures. We try to get in those folks quicker. So when you're an academic center with like 10 or 15 neurologists, you can really get lost in the shuffle, which is why there was a clear need for that, and a pathway to get folks referred. We're small enough here where my nurse or the pediatrician who refers me might give me a call and say, hey, there's a kiddo who just had a new seizure, we need to get him in. And so yes, we're doing that, but it's not like an official clinic. The big thing is we often want you to get an EEG before you come in, so we have some data to go over. If you're driving into Kalispell, we try to coordinate getting that done in the morning, then seeing me in the afternoon, or getting it done locally so it's ready for whenever I see the patient. So yeah, we try to prioritize those kiddos.
Awesome. Anyone else?
Do you offer at-home EEGs, like where you take the stuff home and do that?
Yeah, so those are what we call ambulatory EEGs, and that's one of the first things I kind of asked the hospital to get me when I got here because it can be super helpful. We can do that out of Kalispell, and then Great Falls actually has ambulatory EEG devices as well. So I read for benefits, and we can do it that way. And then we're in talks with Bozeman Health because I know they have ambulatory machines as well in terms of kind of reading for them and having that service there as well.
Okay.
And they can be anywhere from 1 to 3 days, sometimes 4 days in duration.
Cool.
Anything else? so hopefully that was helpful for folks. I apologize for the slightly unusual setting. Hopefully the birds weren't loud. But again, if you guys have questions, if you kind of Google my name or put in Logan Health Child Neurology, or contact info is there. A lot of the pediatricians and primary care docs have my contact info. So if there's somebody in need of epilepsy care, definitely reach out to us or to Jessica through the Epilepsy Foundation.
Awesome. Thank you so much. And if any of you are in central Montana, December 3rd, we're having a little epilepsy meetup at 1 o'clock at the Residence Inn downtown. So if you or anyone in your family wants to come meet some others in the community with epilepsy, we will be there. And then we're having a Billings walk again, May 18th. But other than that, thank you. Thank you, Dmitry. And I hope you all have a very nice Thanksgiving.
Thank you very much. It was very nice. Thank you.
All right. Bye, everyone.